Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Hey everyone, welcome back to Gastro Girl podcast, the podcast that brings you expert insights, real talk, and patient-focused guidance on all things digestive health. I'm your host, Jacqueline Gollin. Welcome to today's episode where we're talking about something that so many patients face but don't always talk about. How can you find relief from your IBS-C symptoms without feeling like you're starting over or losing the progress that you've already made? And this episode is sponsored by Ardelyx. And today we're going to be joined by Dr. Bryan Curtin, who's Director of Neurogastroenterology and Motility at the Institute for Digestive Health and Liver Disease at Mercy Medical Center in Baltimore, Maryland. So great to see you again, Dr. Curtin. Thank you for joining me today.
Thank you very much for having me.
Okay, so we're going to jump right in to this. And let's start where many of our listeners are. Once a patient starts to feel a little better with IBS-C, maybe fewer flare-ups or a little more regularity, there's often this big fear, right, of losing that progress. So why is that fear so common, and how do you help patients understand that treatment doesn't have to be all or nothing?
I mean, it's a very good question. And I think that, just the very nature of IBS, I really think lends itself to some of this uncertainty because, we have, as doctors, have uncertainty when it comes to the pathophysiology behind these conditions. When we make a diagnosis of IBS, a lot of times it's a clinical diagnosis. It's not like we did like a specific test. In other areas of medicine, there can be a lot of certainty. Like we did a scan and we saw a tumor and it's right there and I can measure it and I can see, exactly how big it is. I can do a surgery, I can take it out, and then I can do another scan to show that it's gone. Or I can do a laboratory study, like I can take a look at your liver functions and then we do an intervention and then your liver function gets better. And we can actually point to that as like an objective metric. But when it comes to IBS, a lot of times the kind of feedback that I'm looking for in clinic and what patients are looking for is purely subjective. It's like, how am I feeling? How is my, gas and bloating? How is my abdominal pain? How are my bowel movements going? And even within the realm of bowel movements, I mean, even just asking like how many bowel movements a day, I mean, there's a lot of detail that kind of question misses in terms of, how are these complete, spontaneous bowel movements? Do you feel, like satisfied with the bowel movements? Are you rushing back and forth to go to the bathroom? And so, there's this subjectivity. And as a result, I think the fear comes from the fact that like there isn't going to be necessarily that like aha moment where everything's cured. And I think that leads patients to think, oh my gosh, they start thinking ahead. They start thinking, am I going to deal with this forever? Am I going to suffer with this forever? Like, is this just going to be my life now? And I think that you get into a sort of the spiral where, you're suffering with IBS, which is a very common condition, but then you think, oh, my life is irrevocably changed. This is never going to get better. If I have a setback like that, that's it. Like this is my new normal now. And I think that fear kind of comes from that level of sort of uncertainty. And even though we have a lot of great treatments, both, pharmacologic and otherwise for IBS, I think that fear really comes from that uncertainty with the patients.
Yeah, and with IBS-C, I mean, it can be very painful. And, it's subjective on, the bowel movements. There's not like a number, oh, you have to hit this number every time,
Yeah.
every day or every week. So it makes it even more like you may feel like you're failing as a patient, like, oh, it's not working, or there could be room for improvement, but you're afraid to go to a new treatment because you think this is all you can get to. Which brings me to my next question is what are some of the signs that it might be time to adjust a treatment plan, even if things seem okay? And again, that's a subjective measure.
Yeah, and I also want to touch on one thing you said before I forget is that sort of like performative nature, like what kind of when the patient comes to the doctor, and it's like, oh my gosh, like it's almost like I have to like I'm not doing better, but I have to sort of show it, and that kind of speaks to that. Because there's not as many like tests and objective metrics, especially when patients have really bad flares, they have to go to the emergency department. A lot of times they feel like they're, that they're not performing. Like the ED looks at them like, oh, this is just like a functional bowel problem. Like this is, not worthy of like attention, like, in terms of healthcare. And so I think that performative nature also kind of feeds into this fear as well. And, that's why I think patients, have a lot of hesitations even talking about this. I mean, even to me or to somebody who, treats IBS on a regular basis,
Yeah.
I still hear that kind of hesitation. And it's almost like they're waiting for me to say, oh, that's not worthy of concern, or that's, like, this isn't, to sort of like dismiss them in some way. And I think that we as healthcare providers can probably do a better job in terms of trying to, at least at the very minimum, even if you don't have wonderful treatment options for a condition, you can at least show empathy. And I think that that's really kind of important in this sort of situation. I think that is really where this begins in terms of, having patients have the comfortability to sort of speak up and say something like, hey, like, my bowel movements are better, but my abdominal pain and bloating isn't better. Maybe we need to switch therapies at that point. Obviously, setting expectations is a big part of IBS because I nor no other doctor that treats IBS can promise a cure for it. We just can't. A lot of times when I'm in clinic and I'm talking to somebody with IBS, I'm saying, listen, if I can get things where they are now to like 60 to 80% better than they are. And, sometimes patients will tell me like a certain event that they can't do, or certain activity. Like, I can't go out to dinner because of my IBS, or I can't, I see a lot of retirees where they've been, saving up money and trying to go on trips or go on cruises and things like that. And they can't because now they've got IBS, and, they're really afraid to do that. And then gauging sort of how close or far away they are from that particular activity, I think is very, very helpful. And so I think that, if you have that kind of goal in mind with those expectations, then, that when the patient can speak up is when they're not getting closer to doing those kind of activities that you want. Because even with IBS, we should be able to get you to the point where you can still have, a decent quality of life. Like, that shouldn't just be like we shouldn't just give up on that and say like, okay, like, you're just not gonna be able to go on this. You're not gonna be able to go to dinner. You're not gonna be able to go on a cruise. Like, I think we can probably get you to the point where at least we can find a pathway towards getting that through. So I think, especially when you think about your quality of life as a patient, and you think, all right, what am I not being able to do because of my IBS? If there's major impediments like that, I think that's definitely a time to speak up.
Yeah, that's a really good point. And I want to bring up this question that I've been wondering about. Social media is flooded with lots of stories and testimonies, and a lot of it can be very negative. And
Mhm.
and I don't know if you notice this, and this is not meant, and please, listeners, I empathize with you. I'm a fellow patient with IBS as well. So I have empathy and compassion. So don't take this the wrong way, but I think sometimes patients are so fixated on identifying that they're an IBS patient as opposed to someone who's living with this condition,
Mhm.
and that they lead with that, and they're maybe focused on everything that they can't do or they're fearing, and that creates in itself an anxiety and vicious cycle of worry that could possibly contribute to worsening symptoms. What do you think about that? I mean, is there some truth to that, or am I just going down a rabbit hole? I say this because it alarms me to see the negativity and the fixation, but then there's other patients that are doing amazing things with their conditions all over the world.
I think there's a balance. I definitely think you're hitting on something there, and I think that this is not just in the realm of GI, but I think in the realm
Right.
of medicine in general. And I think a couple of things drive it. I mean, one of them is that, we're more connected than we ever were before. I mean, now people are not just looking at like social media, but they're like asking like AI and like, doing all the, there's a lot more technologies than we used to have. And so patients have the kind of literature and sort of have a lot of information at their fingertips. And obviously, when it comes to conditions like IBS or other medical conditions where maybe modern medicine doesn't have all the answers for those conditions,
Mhm.
it's natural, especially when you're suffering, to sort of look for alternative sources and to look for other people that kind of have your, same story. And to your point about, the negativity, I would say that, there's always going to be that kind of negative bias, because people who are generally doing, like, if they have IBS and they're able to get it controlled really well, they're probably out like living their life and doing other things. They're probably not, on social media, like talking about that. And then, so you're going to have a negative bias, where the people that are more motivated to sort of like really kind of share that information are going to be the ones that are really suffering. And then you get a bit of a distortion, because, all of us are subject to this. We see something, and part of the problem, I think, with social media is that, throughout human history, like, terrible things have happened. Like, human history is full of like, death and war and disease and really just suffering of an untold imagination. But it wasn't something that you were confronted with all the time. And, now, like, some weird, somebody, like that plane crash that recently happened, and
Oh
we
my
see
God,
that
yes.
family, or, the current like military conflicts in the Middle East. Like, we're seeing this in real life. We're kind of experiencing it. And I think that it sort of makes it like it's affecting our life, even though it's not really, we're kind of just seeing on the screen. And sometimes when we see that level of suffering, we extrapolate from that information that, oh, there's like so many other people that are like having the suffering, and this is kind of a hopeless condition. And I think that some people do kind of lean into that because it does give you a sense of purpose and identity. I think that ironically we're more connected, from, with regards to the internet, in regards to social media than ever before. But a lot of the, sort of communities that have developed are communities sort of around, either these kind of like medical conditions, and they're communities in the sense that you're sort of sharing information online, but not in the sense of like that old, like sort of like small town community where, there's no cost to necessarily enter one of these communities. You can exit and leave as you wish. So it's not, it's sort of a facsimile of a community rather than like a real one per se. And so I think that can, I mean, it can be very helpful for some people, I think, who are suffering, to learn that there's other people that are suffering just along with them.
Oh yes.
I do think that there can be a problem where you can sort of go down some rabbit holes when it comes to certain types of treatments, because what works for somebody might not work for somebody else. And then I think that when your disease starts to become integrated with your identity, and this can happen not just with IBS but with
Oh
other
yes.
things, that's when I think you can sort of cross into sort of a more troublesome lane, and that's hard. I mean, this is really difficult to kind of talk about
It's
patients, because patients really get very, I think, defensive about that, because they're suffering. They want help, and so I think it's important to ask these kind of questions and have these sort of frank discussions. And then in modern medicine, unlike a lot of things that are out there that promise these kind of quick cures, like real medicine is kind of sometimes a little bit hedgy and a little bit uncertain, because you have to approach these things with some intellectual humility that maybe we know the answer, maybe we don't know the answer, but these are the tools in the toolbox that I have to sort of try to treat your symptoms and get your quality of life better.
No, thank you for that. And the reason why I brought this up, because I think it goes along with the performative that you said, and also feeling less than, or the negativity feeds you and you think you may be doing well compared to what you were doing last week, but then you're seeing all this other stuff and it just becomes, whether it's playing on the gut brain interaction, and you're more stressed and anxious, which is not helping your symptoms as an IBS patient, IBS-C patient,
Mm-hmm.
but it's also setting a bar that's unrealistic and expectations that can take you off your treatment journey in a negative way. And that's why, and it impact the patient provider relationship, because it may not be helpful when you're trying to prescribe a new treatment or be open to this, right? That's why I brought it up, because everyone's unique is my point, and a long way of getting to this. Everyone's unique, and it's important to talk to your healthcare provider to see if you can raise the bar a little more and what it would take to get there. There are new treatment options for IBS-C, correct? That you mentioned, gas and bloating and pain, that patients could maybe could explore that, but they have to be open-minded to that. And so how do you approach that in your practice?
I mean, I think a lot of it is taking some time. One of the things I hear very consistently from patients these days is that everything feels very rushed. In fact, a lot of times, like when somebody's telling me their story, because I usually, my first visit, I sit down and say, tell me your story, like tell me, like and sometimes I just need to let them kind of talk, and sometimes they'll reveal really helpful information just by telling their story. And sometimes their diagnosis of IBS came literally as they're being like wheeled out of the endoscopy suite, when some GI doctor was like, "Oh, you've got IBS. There's nothing wrong with you," and then they literally kind of make this hand motion, like they're
Yeah.
kind of like sweeping them out the door. And that doesn't really, that's not a really great way to sort of make that diagnosis, because you really have to kind of talk about the gut brain axis and all the different factors that kind of go into IBS. A lot of people will have kind of an instigating factor. It's very common that people will have like some infectious cause, like, oh, everybody went on this trip, everybody got sick, but I never really got better, and now I also have this problem. That kind of post-infectious IBS picture is very, very common. And so I think the first step is just kind of like listening to the patient, and listening to sort of the story, and showing some empathy towards that, and realizing that this is a very common condition. And while, even though we don't have We have a lot more treatment options than we used to, but still, if you look at the clinical trials, most of these agents have, something like a 50% success rate, which led to their approval, which means sometimes there is a trial and error process. And I think speaking to your earlier point about the comparison, I don't actually see that in clinic as much as I might expect, where somebody says, oh, I saw this online where this person got really better, but I didn't. I think that most patients, once they're kind of in that one-on-one setting in the doctor's office, I think that they do a fairly good job of, kind of just, comparing themselves to themselves, because if you compare yourself to someone you saw online, it's kind of like me looking at, if I'm starting a fitness program and I'm looking at like a supermodel, like I'm going to get discouraged looking at that because it didn't, you have to compare yourself to yourself in terms of where you are. And that's true with IBS as just as anything else.
So how do you talk to them? About maybe it's time to adjust your treatment plan, even if things are okay, whatever that means?
Yeah, obviously, okay is very subjective, and a lot of times, I find that patients, in many ways, they'll tell me when it's manageable, when things are manageable. Usually, when I'm talking about a treatment plan, I'm not just saying, okay, this is your treatment. Like, I'm going to pick this medicine for you, and you're going to take it. I usually say, okay, here's what I'm thinking. You're having like a lot of gas and bloating issues, right? And let's say, you've tried some over-the-counter agents. We're talking about like prescription strength agents. I might lay like kind of, not physically, but just sort of like, in dialogue, I might just kind of like lay three options in front. Like I say, okay, you mentioned about the gas and bloating. And like, so in the clinical data, like Linzess or Ibsrela has kind of the best response to gas and bloating. So these are the reasons that I might pick this one. The downside with these is that they might cause diarrhea. So maybe we try something like the vibrating capsule, which has less incidences of diarrhea, but is not as strong in terms of the data on gas and bloating. There are no like head-to-head trials with any of these medications. We're all looking at like kind of parallel trials, but I basically walk them through, okay, here's my assessment. Here's what I'm thinking. These are three options. Here are the pros and cons of each of these options. What are your thoughts? And sometimes patients will have very strong thoughts like, oh, I really want to try that, vibrating capsule. I like the idea of not having like another pharmacologic agent, or I really want to use the best, strongest agent. The other agents haven't been strong enough for me. So I might pick like a higher dose like Linzess or something like that for that instead. So, I try not to sort of anchor myself just one treatment strategy, especially at the very beginning. Sometimes patients have failed several things and then your options start to get narrower towards the end. But at the very beginning, especially if they haven't tried everything, then kind of giving them multiple options. And I think just even knowing that there's other options available, because I think some patients will then, if you only give them one option, they're like, okay, this is it. This has got to work. Like, otherwise, like I'm really, I'm really in trouble. And I think that's where some of the fear comes. This also lets them know like, okay, if this doesn't work, we've got this. And if this doesn't work, we've got this, and like having them knowing that there's options. It's actually pretty rare that I see somebody in clinic that has exhausted literally everything. Most people come in saying they've exhausted everything, but if you actually go through every agent that's available, usually there's a few things there that we can try to sort of improve things.
No, some patients are maybe hesitant to tell their provider that something may not be working because they don't want to sound too difficult. Like, so say if I have IBS-C and, I'm on a medication and it's kind of helping with my bowel movements, but I have this excruciating ab pain still.
Mm-hmm.
Like, but they are afraid. Like, what advice do you have for patients to talk to you? And maybe is there something else they could try? Like,
yeah, it's a good question. I think that, hopefully you've cultivated a relationship with your physician where you kind of feel comfortable, like kind of opening up to them. And you don't just feel like, I think a lot of patients will come to me and they say, oh, I'm being a problem patient. And it's very rare that I actually have a true like problem patient, and if it is a problem patient, it's never because of the medical disease. It's usually like, some other problem, like, them calling the office every day or something like that. It's usually something that's not usually related to the disease
right.
itself. But that's your time. Like when you're in the clinic, especially, I think, it's harder, especially when they're in between visits and they're using like the MyChart messaging or phone calls because just things are so busy these days. But when you're in the visit and you're sitting across, like that's your time. And so you should feel comfortable that like, okay, I'm here to try to get better. I'm here to be honest about my symptoms and saying, like this is really bothering me. And also kind of coupling it, as I mentioned before, if there's a particular activity or impairment to your quality of life that it's really affecting, hey, I had to go to the ED last week, or hey, I had to miss a dinner because I'm having abdominal pain. A lot of times I think it's really helpful for doctors to hear, not just I have pain, because, sometimes they hear pain and there's lots of different types of pains. and coupling it to an experience that kind of speaks to the severity, like, hey, I'm not able to go out to eat because I've got this horrible abdominal pain. Like I'm stuck in my house. Like I'm in my bathroom for 2 hours a day. Like kind of giving that sort of anecdote to touch on the severity, to sort of give it a real world example, I think really kind of solidifies, for a physician who's like seeing maybe, 20, 30 patients a day, like those are the kind of examples that I remember, like those kind of things stick in my mind. And I think that can also help to say, oh, we really need to change therapy at this point.
So, what can patients do to really prepare themselves for that conversation? Do you have them do symptom diaries or little notebooks? Or I know it's really important for patients to be their own best advocate. Can you speak to a little bit about some tips that patients can do in that visit with you?
Yeah, I mean, I think we do have stool diaries. Like a lot of times, like when I'm having patients come in for like biofeedback for dyssynergic defecation, which is very common, that sort of exists alert alongside IBS. Like we send them home with like a stool diary to record. Some people get a little bit overwhelmed by that. There are some new like app-based diaries that have also been
Mhm.
shown to be fairly effective as well. I think the diary thing. I mean, some patients are really into that, and some patients are not. I think that
Right.
having a clear idea of how much better you are, I typically like asking a percentage. Like, are you 20% better, 50% better, 80% better? Because I mean, if you're 80% better, that's pretty good. Like I'm probably not going to be able to get much better than that. So we may not want to sacrifice what we've gained. You don't want to let perfect be the enemy of good, so to speak, in that
Right.
situation. But if you're only like 10 to 20% better, then we're not losing much by kind of switching therapies at that point. I don't think you need to necessarily feel pressure that you have to like kind of prepare this, like like you're prepare like a big document, and some patients do that, and it can be helpful, but you don't need to feel pressure to do that. I think just being as clear and concise in your story, like saying, okay, listen, I've been diagnosed with IBS, I started this medication, I'm not feeling better, or I'm having this side effect with it. My goals today are, and even saying that, like, within the office, like saying like my goals today are, and then saying I'm trying to find a different therapy to see if I can improve this abdominal pain. Like having a clear goal when you come in there, I think is helpful, because sometimes, and listen, patients like to talk, they like to talk about their lives. And sometimes you find out really nice things, you have good conversations, but because of just modern medicine, we're always on the clock a little bit, and so we always have to kind of eventually get down to brass tacks in terms of what the symptoms are. So I think having that from the get-go, like saying, okay, this is my goal today, this is what I need to communicate, and knowing that information, I think that will help even more than any kind of like detailed log or something like that.
Yeah. Do you have a quick example of a patient who was able to adjust, an IBS-C patient who was able to adjust their plan without losing progress, and what helped them stay on track?
Yeah, I mean, I think that every story is a little bit different. I would say that, as an aside, physiologically, like especially with some of these agents like Linzess and Ibsrela, like there seems to be for some patients like an effect where even if you're doing well on the medication for a long period of time, there seems to be sort of like a habituation that the body undergoes. Maybe they downregulate those receptors so that they're not, and so it's very common that even somebody who's on a medication for a very long time, sometimes we need to cycle it. And a lot of times I'll liken it to sort of cycling, like people with inflammatory bowel disease, like they might need to cycle different biologics because they become less responsive to them. And so it's very similar in terms of constipation as well. But I mean, what I would say is that, listen, we've got lots of different options and lots of different mechanisms of action. And so if this medication is not doing well for you, first of all, most patients are going to start off prescription strength with secretagogues. So that'd be like Linzess, Amitiza, and Trulance. Switching in between the classes can sometimes be helpful, and sometimes switching to a different mechanism. You've got like Motegrity, which is a progut kinetic. You've got Ibsrela, which is an NHE3 inhibitor, which is a newer agent. You've got the vibrating capsule. So again, I think just laying all those options out there. In general, I think that laying of the option really kind of helps to inspire patients, because then they know there's a lot of options. Because one of the things I experience, I think, when patients come to see me, and obviously as a motility specialist, I think that scenario is a little bit different, for someone coming to see me, because they're sort of expecting for me to have something new. It's unfortunately, it's very common for people to wait like 6 to 8 months sometimes to see me. So by the time they come in, I think that their expectations sometimes are very high in that sense. So my experience is a little bit different than I think a general gastroenterologist is going to be. But I think that laying out those different options, that's when their eyes light up and they're like, oh my gosh, I feel hope. And that's always very nice at the end of the visit. It's like, okay, I feel hope for like the first time in a while, because when you just kind of leave it as a dead end and you don't have those other options, you don't just want to plan for this visit. You want to say, okay, we're going to do this visit, and hopefully this works. But at next visit, these are the things that I'm thinking about, and leaving it kind of open-ended so the patients don't feel like they're running up against a dead end. And so I think in terms of like talking about inspiring patients, I feel like kind of making sure that there's always some sort of road that's open. I think that kind of fights that feeling that patients might have of being trapped, like, oh, this is it. Like, because I think if they do that, because of just the whole nature of IBS and the gut-brain connection, I feel like, if your anxiety goes up at, oh, this is it, if I fail, then I'm done.
Right.
Then I think that's going to just worsen the symptoms by itself.
Yeah, and this kind of goes to the next question, is the importance of flexibility in IBS care, IBS-C care especially. Why is it so important to shift our mindset from one right answer to what works right now? And you kind of alluded to that. If you can just expand on that a little bit.
Yeah, I mean, I think that, and some patients will come in and say that, hey, listen, I tried like some over-the-counter like herbal therapy, or I tried a new probiotic, and that really seemed to work for me. And, at that point, like you can talk about like, okay, like the data and sort of what the guidelines recommend, and sort of like what the 1,000-foot view looks like from the ivory tower. But, sometimes taking the win, I think, is important in that situation as well. And, and some patients, they'll come back and they'll say that they're taking the medication, but they're not necessarily taking it in the way that I had initially prescribed it. Like I had a lady in clinic today who's taking Ibsrela like 2 to 3 times a week, but it's really working well for her. And so I wouldn't necessarily recommend experimenting with your medications without talking to your doctor necessarily, but I would say that kind of level, there is some improvisation, I would say, with IBS care. And so I think that the flexibility is really about, knowing where there is, appropriate, especially for like over-the-counter medications, like Miralax in particular is very improvisational in terms of how much Miralax you're using. As some of the prescription strength medicines, there's a more narrow window with that. But I think that, kind of being flexible with that and being willing to add different agents. And also for me, I think incorporating, some agents that are not necessarily traditional, like the probiotics and other things, especially if they've already failed some more of the traditional options, like kind of being willing to think outside the box within reason and within safety. I think that that's where that kind of flexibility can come from.
No, those are great points. And I know we're almost out of time, but before we wrap up, Dr. Curtin, what's the one message that you want patients with IBS-C to remember when it comes to managing symptoms without fear of going backward?
Gotcha. I mean, I think that the take-home message is, IBS is a very dynamic condition. And so just because things are going like in the wrong direction, you definitely want to be kind of like open and upfront about that. Even if you've been doing well for a long period of time, you're not bothering your doctor by talking about your symptoms, right? I mean, that's our job. Like that's why we're waking up in the morning and going to work every day. So, please tell us about your symptoms. Try to be like sort of very targeted. And that's why I mentioned talking about the goals. Like you really want to, focus on like, what is my goal? Is it like abdominal pain? Is it bowel movement frequency? And kind of focus on how can I get this better and what other options are there available? And so don't be afraid to sort of talk about that. And it's also very, very normal for IBS patients to kind of go through peaks and valleys. I have some patients that I've seen for years, and they had 1 year where things were just really out of whack and we had to do a bunch of medication changes. And then, I see them a couple of years later and they're like doing great. We haven't made an adjustment. And that's very normal with IBS because there's so many different factors that play into it. I mean, even, your environments, the amount you're traveling, the amount you're working, your diets, that you can change other medical conditions. So it might not be the medications that are making the change. But the important thing is that don't be afraid of some variability with IBS because that's to be expected. And definitely don't be afraid of talking to your doctor about your symptoms.
This is great advice. Thank you so much, Dr. Curtin, for helping us reframe what progress really means, especially in IBS-C, and reminding our listeners that treatment is a journey and not a one-time fix. And to everyone tuning in, remember your voice matters, your experience matters, and your patient journey is unique to you, and you deserve a care plan that evolves with you. So if you find this episode helpful, please share it with someone who needs to hear this. And don't forget to subscribe, like, and share more of our podcast episodes at Gastro Girl on YouTube. Until next time, take care of your gut and yourself. And thank you to Ardelyx for sponsoring this episode.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.